Okay, in this video we're going to finish with the knee. We'll talk about a little bit more pathology to help reinforce the normal anatomy, and then we'll talk about the distal parts of the tibia and the fibula, as well as part of the ankle joint. So looking at the images here, the image on the left shows a normal knee. So note the typical space in between the tibia and the femur and the knee joint. So it should be a uniform, nice gap there, or space, joint space. Whereas over here you can see on the right hand side, this is an example of osteoarthritic degeneration of the knee joint. And so here you can see narrowing of the joint space, and then you also, which is again pointed out by the arrow, and so you can also see where you get some joint instability as a result. You can see how there's slight deviation here of the femur on the tibia as a result of that. Again, there's going to be medial deviation here of the femur as a result of the osteoarthritis in this patient. This is a more extreme example of osteoarthritis in both knees. You can see, so this is a bilateral case of osteoarthritis, and you'll note that there's a clear varus deformity in this patient. There's also large osteophytes, which you can see in the patient, and then severe sclerosis, which is sort of this connective tissue that invades normally healthy tissue in a pathologic state. And then with the varus deformity, just as a reminder on that, remember that means bow-leggedness. A good way to remember that is varus kind of sounds like varum, which is what you do when you ride a horse, and riding a horse leads to bow-leggedness. So again, varus deformity causes this sort of lateral outbowing of the knees. So it's a varus deformity caused by osteoarthritis. Now, I've spoken fairly extensively about the articular cartilages of at least I pointed them out on a number of scans, but we haven't really talked much about their function. So remember that they are a specialized type of hyaline cartilage that are going to help to allow for smooth joint movements to occur. But these are the specific cartilages that are degenerated during or with osteoarthritis, and so that leads to pretty significant pain. So you can see where the femoral condyles are coated with they have a thin layer there of articular cartilage, as does the posterior aspect of the patella that articulates with the femur, and then the tibial condyles are also going to be covered with articular cartilage. So this is just another drawing of the anterior versus posterior knee joint, where you can just appreciate in blue the regions of articular cartilage. So any of those regions are going to be at risk for osteoarthritis. This is another example of a degenerative joint disease, which is known as osteochondritis dissecans. So what happens in this case is usually there's a disruption of the blood flow to the articular cartilage, and that causes degeneration of the underlying bone that's located deep to the articular cartilage, and so that can cause pretty significant pain and joint instability, usually in children and young adults. And so the way that we treat many cases of osteoarthritis, especially, is with a total knee arthroscopy, or TKA. So this is a total knee replacement. And so you can see the basic architecture of these joint replacements. So here effectively what we do is we carve off the anterior surface, or the condylar surface of the femur. And so they do that with a specific joint guide, where the surgeon will then just follow and make these specific cuts that perfectly mirror the implant. And so once that is done, then the implant on the femur can be placed, and usually this is a polished type of surgical steel that we use, or titanium, depending on, again, there's different materials that can be used. And then down here you can see with the tibial plateau, where the same basic thing is done. They just carve off the condylar surface, and then you can see how they can screw these in place, though many of the more modern implants do not actually involve screwing it into the tibia. Instead, it's just this medullary component that goes into the medullary cavity, and then that holds it into place. And then here you can see that there is a sort of a plastic insert that we use in between the two metal pieces, which sort of serves like a replacement of the menisci. And so you'll see on imaging that plastic plate is not visible. You can just see that there's a clear gap in between the two metal components of the implant. All right, so here we have artist rendering of the tibia and the fibula. Remember that the distal ends of each one of these is called the medial malleolus and lateral malleolus respectively. So again, the end of the fibula is the distal end is the lateral malleolus, or forms the lateral malleolus. The distal medial aspect of the tibia forms the medial malleolus or malleolus. All right, so here we have a spiral fracture of the tibia. So you can see that it's quite obvious on the lateral view, but note on the AP view, it's really not evident there at all. So this is just another good example of how important it is to get multiple views of a body part to be able to appreciate pathology or injury. And then here we can see another example. If you look really closely, you can see this kind of two components, but really this is probably the major fracture site right here, which is a transverse fracture of the tibial metaphysis on the proximal end of the tibia. And so one way that we can treat tibial fractures is with intramedullary fixation device. So that's what's being shown here. So you can see intramedullary means it's actually inserted into the marrow cavity of the bone, and that's going to help to reinforce that bone. In this individual, you can see that there are multiple fractures of the fibula here as well, but keep in mind that the fibula is not weight bearing, and so typically you don't really need to do much to reinforce it. As long as the two ends are well approximated, that bone will spontaneously regenerate. Here we have an example of a young female who was complaining of chronic pain in her leg. She was a runner, and if you look really closely at the fibula, you can actually see that there's a small defect there. So on the next slide, here we have a zoomed in view of a healing stress fracture. So again, this was just a minor fracture affecting the fibula, and so we can see that this is evidence of that fracture healing, and so that was the cause of pain for that patient. So looking at an AP view of the ankle here, this is obviously just an artist rendering, but keep in mind that the tibia as well as the fibula, but mostly the tibia, is going to be articulating here with the talus. So the talus is going to be forming, so this is the tibiotalar joint right here. And so remember that both of those surfaces are going to be covered with articular cartilage, and you can see here where the lateral malleolus of the fibula is also articulating with the talus as well, and then just anterior to that is the navicular bone. And so this is important to evaluate in X-ray, in conventional radiography. You want to be looking for this sort of typical AP mortise, where the talus and the tibia should be pretty much exactly parallel to each other, with the tibia perpendicular, coming out perpendicularly off of the talus. So here we have a view of that typical AP mortise. So again, you can see how they're well aligned horizontally as well as perpendicularly to each other. Here you can see the medial malleolus and the lateral malleolus there of the fibula. So then looking at a couple of different classification schemes that we use this for what's called a Weber fracture. And so this is going to be where we have a Weber A fracture is a fracture distal to the ankle joint that's affecting the fibula. At the level joint is Weber B, and then proximal to it is a Weber C. So again, that just kind of an FYI for you guys there on how we classify these fractures relative to the ankle joint. All right, so looking at a anterior and posterior view here of the ankle joint, you can see again the tibia sitting on top of the talus, and then we can see over here on a posterior view, you can appreciate the calcaneus and the talus here, and then note the sustentaculum tali here in these views as well. All right, so in this case, in this patient, we have what's known as a bimalleolar fracture. So both the medial malleolus of the tibia as well as the lateral malleolus of the fibula have been fractured in this patient. And note that on the fibula, the fracture is located approximately at the ankle joint, and so that would be a Weber B fracture. And so this would require ORIF procedure. So again, an open reduction internal fixation. So you can see obviously this rod that's been placed on the lateral aspect of the fibula with multiple screws to help place that. Another screw that was placed directly in the bone over here. So again, that helped to reduce and then fix the bones in place, and then over here you can see 2 screws that were placed in order to fix the two components of 2 fractured components of the medial malleolus, and then here you can see the talus sitting right here across the tibia and talus, so forming a nice ankle joint there.